Hello everyone. All right, welcome to my YouTube channel. So today I have another question that someone sent to me, and I thought I should also put it in the public domain. Perhaps it's going to help many of you guys during your interviews. Okay. All right. So someone has sent me this question: key reasons for issuing blood products. Key reasons for issuing blood product. Anyway, before we continue, my name is Dr. Emmanuel Obodo. I'm a biomedical scientist and I'm also a lecturer in biomedical science here in the United Kingdom. Right, let's look at the key reasons for issuing blood product. Okay, right. So someone sent me the question saying, list one key reasons when the following blood products are requested. For example, that is, if I may say, one reason for each product. Okay, right. So now, obviously, I had videos on this already, but because of the way the question came, I thought perhaps I should be able to answer it for you guys. Okay, right. So I want you to notice what this question is talking about. First of all, for you to be able to understand this question or to answer this question very well, you've got to understand the things that they've listed here: cryoprecipitate, irradiated platelet, phenotyped blood, HLA matched platelet, fresh frozen plasma. So now, these are blood products, by the way. Okay. So, for example, when you talk about blood and its product, you are looking at, like I had said before, the cellular part of the blood and the liquid part of the blood. In the cellular part of the blood, you are looking at things like red blood cells, you are looking at things like white blood cells, you are looking at things like platelets. Okay, right. In the liquid part of the blood, you are looking at things like plasma or serum, as the case may be. Now, before I move into this, there is something I really want to quickly bring our attention to. So, platelet is a cell. It's called thrombocyte. So, it's a cell. It's not the liquid part of the blood. But I want you to know that in order to preserve this platelet, because of its activative nature, it's important that we preserve it to make sure that we keep the platelet busy. If you understand what I mean, meaning we need to continue to agitate the platelet so that it's not going to aggregate or activate it. And that is why we usually mix the platelet with plasma. All right, okay? Now, when we say cryoprecipitate, it is still a plasma. It is still a liquid part of the blood that contains some certain kind of proteins. Significantly, it contains fibrinogen. Okay, right. Platelet is platelet, like you know, is a thrombocyte. Now, the other one is fresh frozen plasma, which is the last one. That fresh frozen plasma is a plasma, like it's a liquid part of the blood. But in this plasma, you have significant amount of clotting factors. Now, the difference really between cryoprecipitate and fresh frozen plasma is that cryoprecipitate contains significant amount of fibrinogen, while fresh frozen plasma contains significant amount of what? Clotting factors. Does that make sense? Okay. It doesn't mean that it contains clotting factor does not mean that it doesn't have some fibrinogen. That's not what I'm saying. We are looking at the concentration. So in cryoprecipitate, there is high concentration of fibrinogen, while in the fresh frozen plasma, you have clotting factors. Okay? Right. Having said this, because the reason why it's important to differentiate this is that fibrinogen is one of the clotting factors, by the way. Okay? So, but in cryoprecipitate is suggestive, we'll see just mostly one of these clotting factor, which is fibrinogen, while fresh frozen plasma contains several clotting factors. All right, okay. So we've said that. Now, when we say irradiated platelet. Now, what it just means is that this platelet has been passed through a radio light. Okay. Now, for you to be able to answer this question, you've got to know why are they passing the platelet on radio light. It's not just on platelet. Sometimes it can be done on red blood cell as well. So, why are we passing it on radio light? So, you will see we are passing this on a radio light because, let me give you the foundation before answering this question. Now, what happened here is this. Remember when you centrifuge your blood, your whole blood, the red cells is going to sediment, followed by the buffy coat, followed by the plasma. Now, if you remember your sedimentation techniques, you are going to see that the buffy coat is likely to contain, or is going to contain, the platelet and white blood cells. Okay, so what happened is this. In an attempt to separate the platelet, there can be presence of white blood cells. Okay, especially something like what? Lymphocytes. Does that make sense? Okay, so when you say that, because that will help us to understand HLA type. Okay, so when you say that leukocyte that has been mixed with the platelet, okay, what happened that is not a problem if the person is not immunocompromised. However, in a case of immunocompromised patient, these white blood cells, especially like lymphocytes, that has been separated along with the platelet, that little amount of the white cells that mix with the platelet during that separation. Remember, the buffy coat contain platelet and white blood cells. So in separating the platelet, there can be introduction of some amount of what? White blood cells. Now, what I'm saying is this. That white blood cells, when you transfuse someone with platelet, that will also mean that white blood cell has been transferred to that person, has been transfused into that person. Now, if the person's immune system is okay and competent, it's not a problem. It's going to get rid of that very white blood cells. However, if that person's immune system is compromised because of the weak nature of the person's immune system, that white blood cell will continue to float on the person's system and continue to, increase in number, and the increase in number will now in turn it will start attacking the host. Okay, it will start attacking the host because it will become a foreign body now trying to attack the host. Okay, and in order to prevent that attack, we will pass the platelet or red blood cell or any blood product on the radio light. So what the radio light will do is to destroy or inactivate the human leukocytic antigen. That's the HLA type now. Okay, that will destroy the human leukocytic antigen. That is the human leukocytic, that's white blood cell. So human leukocytic antigen, human white blood cells antigen that can be possibly introduced with the platelet. So the radio light will destroy it or inactivate that human leukocytic antigen. Therefore, when we give irradiated blood product, one of the reasons why we do it is to prevent graft versus host disease, which is what I had already explained, that due to the patient condition, if we give the person platelets without introduction of the white blood cells, it will affect the patient because of the patient condition, because of the immunocompromised nature of the patient condition. I hope you now understand irradiated blood product. I'm indirectly giving you the clinical reason why we issue that, okay? But now, when you talk about phenotype, in phenotype blood, what exactly is phenotype? I think before I go into that, since I'd already talked about irradiated, let me perhaps continue with the HLA type. So now, if the irradiated radio light destroy human leukocytic antigen, that will now make us to understand what is human leukocytic antigen typed / matched platelet. What we call it is HLA matched in the blood. Okay, sorry, in blood bank. So we say HLA matched. Now, the same way you can cross match someone's someone's blood against the donor's blood, as the case may be, to see whether they are compatible. So because if you see this immunocompromised patient, like leukemic patient, okay, or this cancer patient, so because their immune system is compromised, even though you are passing the radio light on the platelet, there's a possibility that that radio light may not destroy all the white blood cells that may be present. Okay, so in order not to take that chance, what we can do then is to come to a point where we are able to cross-match the possibility of the similarities between the donor's human leukocytic antigen and the recipient human leukocytic antigen. Does that make sense? Okay. So now, what we are going to do that, we know that when we are separating platelets, we are likely to introduce white blood cells. Then we now say, okay, because this person's immune system is compromised, let us first of all cross-match the patient's white blood cells against the donor's white blood cells. So if they are compatible, it kind of helps to solve the problem of the patient system seeing the donor leukocyte as a foreign antigen because they are not compatible. Do you understand, guys? Okay. So what it means that in HLA match, it doesn't stop us from introducing radio light, which is irradiated platelet. Okay. We will still do irradiated platelet, but the cross match will help, where possible, to make sure that that little amount of the white blood cell perhaps that is not destroyed by the radio light is compatible with the patient. So that is what HLA type or HLA matched platelet is talking about. Cross-matching the patient cells against the donor cells as in regard to human leukocytic antigen, which, if it is not done, can lead to graft versus host disease, as I had explained. I'd already answered most of this question. So, because after this explanation, I'm just going to tell you the answer, and that will be the end of the video. Okay? Right, let's look at the phenotyped blood. What do we mean by phenotyped blood? So, what it means is this. You know that the blood, or red blood cells, if I may say, when you hear blood in blood bank, it's red blood cells you're talking about. Okay? So, these red blood cells, they contain, you already know, maybe antigen A, antigen B, or whatever, okay? Or no antigen. Now, I said that, of course, on my previous videos, that every red blood cell has antigens, known as IgG antigens. A simple thing as saying A positive means that that blood has D antigen. A simple thing as saying A negative means it does not have D antigen. So we have IgG antigens liters on the surface of red blood cells. Okay, right, good. Now, at which point do we need to give a phenotyped blood? Now, let me explain what this is talking about. Especially maybe in a case where there is a history of antibody, or maybe that's the first time you are isolating the antibody. But where possible, once a patient has antibody, either a historic antibody or a current antibody, is important, where possible, that we give the person a phenotyped blood. Let me explain what I mean. It means that if someone's blood group is A positive and the person has anti-Dufi A, it's important that we give the person a phenotyped blood of Dufi A negative. Do you understand? Okay. Now, because if you don't do phenotype of Dufi A, you will not know. So if you isolate anti-K, anti-M, anti-N, whatever kind of IgG antibodies you may have isolated, what it means that if someone develop any antibodies, any of the antibodies, it means technically that the person does not have the antigen. And like I said on my previous video, if the person do have the antigen, that is then auto-antibodies. But if the person acquire the antibodies, meaning the person doesn't have the antigen of the antibody the person developed, that is allo-antibody. So I think that this question is based on allo antibodies, by the way. So this person, if the person has antibody, for us, we now need to give that antibody the person developed, we need to get a blood that is that antibody antigen negative. For example, if the person developed anti-Dufi B, you need to get blood that is anti-Dufi B negative, okay, and cross-match for the patient. So that is what they mean by phenotyped blood. So phenotyped blood is a blood that shows you the antigen, the IgG antigens that are positive on that blood and the IgG antigens that are negative on that blood. So we use phenotyped blood when we are trying to issue blood or cross-match a blood product, when we are trying to cross-match a blood or red blood cell to someone who has developed antibody that has developed antibody. So we cross-match the phenotype blood of that antibody the person developed, the antigen negative. I hope that makes sense. Okay, right. I've given us the clinical reasons for issuing all of these blood products, but let me just try to answer it. So why giving cryoprecipitate? We give cryoprecipitate because it's rich in fibrinogen. So in a case of low fibrinogen, we issue cryoprecipitate, right? We give irradiated blood product because it helps to prevent graft versus host disease. I've already explained that, okay? We give phenotyped blood because it helps us to select a suitable or possible compatible blood product following the presence of antibody in a patient sample. For example, if someone is developed antibody K, or if somebody developed antibody E, or if somebody developed antibody C, we need to give the person a phenotyped blood that is that antibody antigen negative to cross-match and give to that patient. Does that make sense? Okay, right, of course, if compatible. Now, for the HLA typed, we also give HLA typed match platelet because I had already said that will help to prevent the possibility of that little amount of the white blood cells that irradiated blood product may not have taken care of, because the HLA type match means that there's a compatibility between the donor's human leukocytic antigen and the recipient human leukocytic antigen. That way, we will no longer be concerned of the possibility of graft versus host disease. Again, HLA type match platelet help to prevent graft versus host disease, and this is more important to be able to make sure that the issues, possible issues that may rise even after the irradiated platelet, will be addressed here, because then there will be similarities between the patient human leukocytic antigen and that of the donor's human leukocytic antigen. Therefore, we are no longer going to be worried about graft versus host disease. So again, it prevents graft versus host disease. And of course, fresh frozen plasma, will give it in a case where there is a factor deficiency, okay? Then we can give fresh frozen plasma, because it then helps to supplement, okay, or augment the factors that may be present in that patient. So when someone has a factor deficiency, we can give fresh frozen plasma, and that helps to correct that deficiency where possible. I think I've answered the question, okay? Right. Thank you very much for listening. And I don't know if you have any question. Please, if you do have any question, feel free to put it on the comment section, okay? And can I ask you to like, share, subscribe, okay? Thank you very much, and I wish you all the best till I come back away again. Bye-bye.